Thank you very much, Dr. Mahapatra, and my chairpersons, special Dr. Bharat Shah. Hypertension, renal evaluation. Kidney, this Arthur Guyton in 19th century told us that kidney is involved in genesis of any types of hypertension. So all forms of hypertension are ultimately consequence of resetting of pressure natriuresis relationship. Dr. V.T. Shah said that secondary hypertension, kidney is responsible almost in 95% of cases. But I feel that even primary hypertension, kidney is the main culprit. Because of this junk processed food that we eat, taking too much of sodium and less potassium, even primary hypertension, it is mandatory to do the renal checkup. And if you see here, a normal salt intake, okay, but the moment you take higher salt intake, the pressure natriuresis curve shifts to the right if you have a lesser number of nephrons. So right from beginning, if you are a premature child with oligonephrons you are born with, and then you develop metabolic syndrome where there is a deficit renal insufficiency, you tend to develop what is called as a salt sensitive hypertension. So the renal checkup is absolute mandatory. So we know that hypertension in people without renal dysfunction also is around almost 50 to 60%. But when it comes to CKD, almost 90% have hypertension. The unfortunate thing is they are unaware of their deteriorating kidney condition. And to assess the renal function right in the beginning or screen them for that is very important to prevent further progression of deterioration of renal function. So hypertension, we all know, is a strong independent risk factor for ESRD, and patients with CKD develop hypertension much earlier during the disease, and which leads to further worsening of the renal dysfunction and cardiovascular morbidity and mortality. So hypertension prevalence in different stages of CKD, from stage 4 to 5, it's almost 84% to 90% of them are hypertensive. So it goes like that. The systemic hypertension leads to intraglomerular hyperfiltration and hypertension, leading to nephrosclerosis and loss of renal function. The common two problems, diabetic and hypertensive, this exactly happens. The efferent arteriole vasodilates, especially this happens in diabetics because of tubuloglomerular feedback, because SGLT2 will reabsorb all glucose and sodium. So lesser sodium will reach the macula densa, and that will dilate the efferent arteriole. So blood entering the glomerulus is at much more the higher pressure. And at the same time, because of angiotensin 2, there is efferent arterial vasoconstriction. So both these factors leading to intraglomerular hypertension and microalbuminuria. So way back in 2006 and 5, people have said, again, that urinary albumin excretion is a predictor of development of hypertension. Let it be primary or secondary. So low-grade albuminuria is risk of hypertension and blood pressure elevation. 1 in 3 diabetics have hypertension, 1 in 5 hypertensives have CKD. The CKD, just to summarize, how do we diagnose CKD? More than 3 months abnormality of renal structure or function, meaning either urinary abnormalities or radiological abnormalities, proteinuria more than 30, albuminuria more than 30 milligram per gram, or GFR less than 60 ml per minute. We diagnose as CKD. We classify them into 5 stages according to the GFR and proteinuria. And this is a very classical heat map, shows that the green is a low risk, yellow is a moderate risk, orange is a high risk, and red is a very high risk. The nephrologists normally don't depend on very high-fi investigations. We just need to check blood pressure, and as my previous speakers have said, the home blood pressure measurement is more important. Ambulatory blood pressure measurement is second most important, and we look for eGFR and for proteinuria. So the lower eGFR is, the previous speakers have again said, is associated with resistant or refractory hypertension requiring 3 or more or sometimes even 5 antihypertensive drugs to get the BP under control. There is almost 30 to 40% incidence of masked hypertension, and the nocturnal drop of blood pressure, as Dr. Ponda has said, is not there in CKD. In fact, there is a reverse elevation of nighttime blood pressure values. Again, the previous speakers have made my job much easier. So when it comes to hypertension and kidneys, we got to just monitor eGFR, microalbuminuria, and Dr. Vitisha has again highlighted electrolyte, importance of seeing electrolytes, because potassium hypokalemia may be an indicator of endocrine disorder or a renal dysfunction. The common, again, Dr. Vitisha has enumerated all of them: glomerulopathy, tubulointerstitial, polycystic kidney disease, renovascular hypertension. This is a very crucial slide. How chronic hypertension leads to CKD through two major pathways. Chronic hypertension damages preglomerular arteries and arterioles that stimulate glomerular ischemia. Similar to what my previous speaker Nikhil Gokhale said in eye, what happens to the eye? Same thing happens to the kidney. So this glomerular ischemia leads to progressive luminal narrowing and a reduction in glomerular blood flow. Chronic hypertension contributes to loss of autoregulation of efferent arteriole with subsequent transmission of high systemic blood pressure to the glomeruli. This leads to hyperperfusion, hyperfiltration, which leads to structural glomerulosclerosis and progressive loss of renal function. Again, the story is complicated, whether chicken or egg story. Hypertension has been recognized as a major factor responsible for decline in kidney function in patients with diabetic and non-diabetic kidney disease. On the other hand, among patients with CKD, high blood pressure may develop early during the course of disease and contribute to adverse outcomes. This is a very popular slide again. JNC said that we all lose around 0.75 to 1 ml of GFR every year. But if the pressure is uncontrolled, we may lose almost as much as 10 to 12 ml of GFR every year. So this kidney has a protective device at the level of efferent arteriole. If there is increased perfusion pressure, efferent arteriole vasoconstricts. If there's a decreased pressure, like all our ICU patients, the efferent arteriole vasodilates to maintain the GFR. So this is called renal autoregulation and maintained by efferent arteriole. But when that fails, the systemic hypertension transmitted into the intraglomerular hypertension leads to loss of nephrons, further loss of nephrons, and this is how the renal damage continues. As we can see here, the primary hypertension usually behaves like a benign nephrostenosis. For years together, it does not produce much of a renal damage. Only when it grows into a malignant nephrostenosis that the renal damage is exacerbated. But in CKD, the slope is very steep right from beginning. So the deleterious effects are observed with even mild to moderate blood pressure elevation in CKD patients. So hypertension is closely associated with progressive kidney dysfunction by glomerulosclerosis and by chronic hypoxia leading to tubulointerstitial fibrosis. So the deadly duo is obviously the diabetes and hypertension, and of course other renal glomerular disease, polycystic kidney disease. So now coming to my today's talk, basically the early screening and intervention is very crucial because it will retard further progression of kidney disease. So all those hypertensive patients, especially beyond 50 years of age, with low baseline eGFR, prematurely born with metabolic syndrome, presence of obesity, diabetes, and family history of kidney disorder or cardiovascular disease are likely to be more vigorously screened for renal dysfunction. And the different markers are, of course, urinary abnormalities, simple thing by dipstick method, we can see proteinuria or RBCs or leukocytes. Then urine sediment abnormalities, electrolyte and other abnormalities for tubular disorders, imaging abnormalities, and very rarely we resort to kidney biopsy just to diagnose hypertensive nephrostenosis. This is very, very rare. So the early screening and intervention may retard the progression of kidney disease. So again, I summarize again: more than 50 years, diabetes, metabolic syndrome, urinary stones, urinary infections, hyperlipidemia, history of anemia. Many a times anemia, the clue that it is of renal origin is unknown till the case is referred to gastroenterologists and scopies are done and referred to hematologists. And finally, we conclude that it was all because of CKD. Family history of CKD and smoking. See, reverse is true in hypertension. Dr. Vitisha has said this is because of salt and volume overload or sympathetic overactivity, renin, angiotensin, aldosterone system elevation, hyperfunctioning, or tubular handling of sodium, potassium, or gain and function monogenic disorders of kidney. So this was a very popular study, that chronic renal insufficiency cohort study showed that almost 85 to 0.7% of CKD patients had hypertension. The simple thing what we nephrologists do now is we don't ask for 24 hours urinary protein excretion because it is messy and gives a wrong reading. So we do albumin creatine ratio. It is now categorized as 30 to 300 and more than 300. 10 is a normal level in normal person. 10 to 30 is mild. 30 to 300 is moderate, and more than 300 is high albumin creatine ratio. The creatinine assists in so that the albumin levels, which would vary with the urine concentration, that problem is obviated when we do albumin creatinine ratio. This microalbuminuria terminology is given up now: mild, moderate, and severe. Then creatinine is an insensitive marker of renal impairment. We all know that till 60% of renal dysfunction occurs, the creatinine remains normal. So we go for this Egfr calculation, and now we have this calculator, this formula. It is on the palm top or laptop. You just feed this formula, and it varies according to the age, sex, body size, and it declines with age. These are very popular formulas, Cochrane and Gold, for dosing of medications we can do on the bedside level. But the most important now is CKD AP formula, which not only utilizes creatinine but also cystatin in this formula. So as you see, glomerular filtration rate categories worsens as you have worsening of hypertension. More severe or malignant hypertension is a severe renal dysfunction. Now, this albumin creatinine ratio and EGFR should be measured while managing these cases also with antihypertensive treatment. So both ways, for diagnosis and during management. Abdominal ultrasound and duplex for renovascular hypertension, for renal sizes, for polycystic kidneys is very crucial, important. So eventually it boils down to urine albumin creatinine ratio, EGFR, and sonography or Doppler study of the kidney. Only cases which have less than 30, that is CKD stage 4 or acute kidney injury or very abnormal urinary sediments or hypertension which is refractory to treatment, should be referred to nephrologist. So to conclude, friends, the simple tests like blood pressure measurement, serum creatinine, EGFR, albumin creatinine ratio, and blood electrolytes would suffice, but it should be repeated at least annually. A single reading is not important. We have to do it, at least check it at least 3 times in a year. So hypertension is most common comorbidity in patients with CKD, almost affecting 92% of patients. Prevalence of hypertension increases with declining renal function. Control of hypertension is a major priority in management of CKD because it would slow down further progression of renal dysfunction and would reduce cardiovascular morbidity and mortality. So elevated blood pressure can occur as a result of CKD and also as a potent risk factor for CKD progression. Thank you very much for your kind listening.